Thank you for joining us. This is Jen Gross at PointRight and my colleague Pam Kaiser, and we're happy to have you on our presentation today. So today we're going to talk about PDPM and the Phase 3 requirements of participation. Both of those big changes are coming our way later this year, so we thought we would cover both of those bases in this latest session. As we get started, just remember that there is a CEU credit attached to this presentation if you're attending live. We are accredited for one contact hour for nursing home administrators and one for nurses. So we'll give you that information at the end of the call. And also there's a handout for the presentation. Just click on the Go to Webinar toolbar and click the link to download the PDF of these slides. And lastly, if you have any questions during the presentation, just use the chat and we will do our best to answer them either in the call if there is time, or we'll follow up by email. So again, our usual disclaimer for the webinar series on PDPM, since the situation is continuously evolving. The latest proposed rule that just came out last month, CMS continues to make tweaks and refinements to this new payment model. So the information in this presentation is based on the current, most recent information that we have available to us at this time. So let's recap our PDPM webinar series, because this is number 6 in a series, if you can believe it. We've gone through the basics of PDPM. Pam gave an overview of all the components of PDPM and the different pieces that combine to make the payment amount for an individual resident day under the PDPM system. Session 2, our colleague Paula DiNatale gave a good overview of the non-therapy ancillary component of PDPM, which is quite different from how we handle things under the RUG system. So there's a lot of very detailed clinical information that's involved in the PDPM drivers, including various clinical MDS items as well as very specific ICD-10 codes. So these are the links to view those recorded webinars. Session 3, I talked about the ICD-10 codes, which are going to be extremely important in PDPM, as well as the concept of the primary diagnosis, which is going to be new as of October 1st, and how that will drive the PDPM clinical categories for a particular resident. Session 4 covered the ADL function scores. Now section GG is driving the bus in PDPM. I talked about the different function scores for PT, OT, and nursing clinical categories, and how section GG scores are calculated is different from the RUG-4 ADL scores. It's actually turning our concept that we have in our heads from RUG-4 upside down. So we're going to have to become accustomed to a very different way of looking at ADLs. The most recent session before this one covered the financial moving parts. So Paula and I talked about the various things that may change a resident's PDPM reimbursement after the beginning, the beginning rate that is set on the 5-day. So of course the variable per diem adjustment happens no matter what. There is the concept of the interim payment assessment that would reset the base payments for one or more clinical categories with a change in clinical condition. And as well as the interrupted stay policy, the possibility that will be new under PDPM of attaching 2 parts of a Medicare stay together if there was a break in that stay in the SNF of less than 3 calendar days without having to create a new 5-day assessment after readmission. So a lot of moving parts that we'll need to become familiar with and comfortable with as we chart our course in the PDPM world. So today we are going to talk about both PDPM as well as Phase 3 that is coming our way under the revised requirements of participation. So we're going to talk about the new updates to the requirements of the participation, particularly how it impacts compliance and QAPI programs. We'll also talk about pieces of PDPM that are, CMS has already kind of been signaling are potential red flag areas for compliance concerns and areas that you should definitely keep an eye on. And if there are areas of concern, we'll talk about potential ways that you can leverage your QAPI program, which is part of the Phase 3 requirements of participation, of course, to dig in and address these areas that are potentially putting you at risk under the PDPM model. So what we hope you leave with after this webinar is an understanding of where these requirements intersect with each other, because this is all coming from CMS and they're all driving towards integrity of the Medicare system. So we hope that we'll be able to outline for you where these two pieces intersect with each other. Hopefully in your own heads, you'll come up with some very specific aha moments around PDPM. So what I mean is something that we will say is will spark an idea in your head, because all of you are in different facilities, all of your residents are different, so PDPM will look very different for your facility versus the facility down the street. It's no longer going to be an RUC is an RUC no matter where you are. So hopefully you'll have some ideas in your head based on your own resident population in your facility that will light that light bulb. Now, this will probably lead to some homework for you. Those light bulb moments may lead you down the path of QAPI, root cause analysis, other further review of the systems and policies and procedures that you already have in place. But this should help you map your course forward into the realm of PDPM and beyond. So with that, I'm going to toss it over to Pam Kaiser, and she is going to give us the lowdown on the Phase 3 requirements of participation. Hi, Pam.
Hi, Jen. Great. Thanks for that intro and for the going over the learning objectives for everyone. So what I wanted to talk about today are the requirements of participation, which, as Jen mentioned, are fast coming upon us. They, in fact, start at the end of November. So we just really get our feet wet with PDPM, and we have this other requirement that we're going to have to get our arms around. So next slide. One of the things that that happened is, again, well, first of all, I just have to let folks know that I tend to use requirements and rules interchangeably. So I really mean the requirements of participation, even though I may say rules of participation. Just a little quirk that I have evidently. So it's the first time that this big body of information has been reorganized, updated, sort of dusted off, right? We've had a lot of this information in front of us. Surveyors had it, they had it in separate letters, but we really didn't have it all sort of reviewed, finalized, ticked and tied, and sort of brought to the current state with knowledge we know about health and safety information. And in addition, some of the changes that you see in these, the rules of participation come right out of the Affordable Care Act. So they're codified at this point. And where in some cases things may have been voluntary at one point in time, like your compliance and ethics program, now it's a requirement under the rules of participation. And really what they wanted to do was align the goals of the SNF provider and CMS with the current healthcare objectives, right, that the Health and Human Services are looking for. They wanted to make sure that everything we were doing was in alignment with what their overall goals were. And those were primarily that they wanted to reduce unnecessary hospitalization. So we've been working on that for a while, and that will continue. They want to make sure that there's work done on reducing healthcare acquired infections. Some of that comes right in on the Phase 3 requirements of participation. They wanted to make sure that we were working towards better behavioral health care, and also that they're safeguarding nursing home residents when we're looking at the use of psychotropic or antipsychotic meds, that they weren't being used unnecessarily. And they really, as the slide shows, came in 3 phases. The way they broke it down was, how much of a lift was it on the side of the SNF provider? Was it, something they should have been doing right along? And so that may have been on phase 3, or phase 1 rather. And by the time we get to phase 3, they're really looking at elements or requirements that would take a lot more time to implement. Many of them require potentially hiring personnel, training, implementation of additional new systems. Next slide, Jen. Great. So under phase 3, there's a number of new policies and procedures. There's new programs, training, and things of that nature. And what we're going to cover are some of the ones that when Jen and I sat down to look to see, here we are with PDPM and here we are with ROP, where do they cross over, and where can we potentially leverage systems? So we're hopeful that by the end of this presentation, as Jen mentioned, you'll walk away with some ideas of how you can tweak or change things you're doing to serve both needs. So under the new policies and procedures, you need to have policies and procedures around compliance and ethics. Now this, it kind of came a little bit of a surprise to me because, compliance has been around for a long time. We've had OIG investigations, compliance agreements, and it's been around since really the early 2000s. And, had some updates to it, but never was really a requirement. Up until this point, it's always been a voluntary type of program, even though CMS has been really focused on it and encouraging people strongly to have those programs in place. Also, the QAPI program, again, another ACA, Affordable Care Act requirement. And we've seen QAPI in each of the phases so far. And what this is doing in this last phase 3 is tying it all up in a nice bow, talking about how your teams are going to be collecting the feedback, how you're going to collect additional data, how you're going to monitor those systems, and then what is your global systematic approach for QI? How does that tie into what you're doing now, and sort of, again, close the circle, close the loop on that whole QAPI program. And so again, for under the new programs, you're going to update what you have for QAPI, add a few data collection and monitoring elements to it, and then also really devise, if you haven't had something in place already, a new compliance and ethics program. Also in phase 3, you're going to have to look to see potentially add some staff positions depending on how big your organization is, and then have some certification requirements. So there will have to be in each center a compliance contact, somebody that your team knows to go to if they have an issue or a concern. There needs to be somebody that's going to oversee the compliance program in and of itself. They may be the same person, but not necessarily, but someone has to perform those functions. In many places, you'll have to have a compliance officer. And again, depending on the size of your organization, you may have to have a compliance liaison in each of the buildings. And you'll have to have someone designated as your infection preventionist. This is a person that will participate in your QAPI program, and that role is written into the expectations of a QAPI program. So an infection preventionist is a must-have as well. When we start to look at the in-services and education that will need to happen for your staff and your team members, definitely training around the QAPI program, what it is, how you do, what you look at, that kind of thing, and absolutely compliance and ethics. When we look at, again, sort of globally, are there processes that need to be added or adjusted? Do we have systems that need to be changed or tweaked? Or are there assessments that need to be done? So in phase 3, we don't have as many assessments that need to be done. That's sort of building on work that you've done in the prior 2 phases. But you will have to look at a system that's going to collect information or data from all your departments. And then how are you going to establish and monitor key performance indicators? So what is it that you want to check? What do you consider for your center a KPI that you're going to be watching and following? How are you going to monitor that? And how are you going to collect data from all departments, from everybody? Because we all know that collecting a good cross-section of data that shines the light on the entire system is important when you're making decisions. If you're too narrowly focused, you may miss an indicator that really can help you to the root cause of a problem or a concern. You need to make sure also that your system to look for compliance violation is in place, that it's able to detect ethical and compliance violations, and that your team has a way to report their concerns. And then you also have to have a process in place to make sure that the data that's reported is of good integrity, right? It doesn't help you to, again, try to improve a system if what you're looking at that's informing your practice is really poor data. So it needs to be a data-driven decision, but you also have to have some sort of process to make sure that that data is sound, so that when you're making clinical judgments around care processes, or you're looking at compliance concerns, that you're well informed with the information that you have. Next slide, Jen. Focusing on the compliance and ethics components, when you develop your written compliance and ethics standards, you need to have, comprehensive policies and procedures as well. There are some specific criteria. You have to be sure that you can identify and decrease the likelihood of violations, right? So you have to set up a policy or practice that helps you identify those areas. So usually you focus on areas of high risk or things that happen quite a lot, or if something happens once and it's of such an egregious nature, you need to make sure that you're addressing those. And that's sometimes what we think about when we're trying to make sure that you've crafted a policy and procedure that addresses those issues. When we're looking at compliance and ethics, sometimes what gets lost is this concept of quality of care. It's written and it's part of a compliance program that you're promoting quality of care delivery to your residents. So sometimes people tend to think about compliance as to catch a bad actor when we talk about billing, right? That we're upcoding, that we're changing coding, that we're, doing these things that would impact our reimbursement, and that's solely the focus of compliance. But compliance also means that we're providing quality care, and so ensuring that you have that process in place is critical. You also have to establish a person that folks can report violations to. It has to be, so again, if you're preparing for survey and someone's going to come in and, assess whether or not you have a compliance or ethics program in place, you're going to want to make sure that any of your staff members, when asked who is their compliance person or is there someone that you take your concerns to, that they know who that is. And you also have to make sure that there's a method for reporting that anonymously. So sometimes people just aren't comfortable bringing something up that may be of a sensitive nature or sensitive for them. So you have to have that availability. And they cannot, there can be no retribution. So your employees shouldn't be fearful that if they identify an issue or concern, that it will have a negative consequence for them. The other thing that's important when we're talking about compliance and ethics is ensuring that once you develop a plan, that you have people within your organization that are enabled to carry that out, that have the responsibility for oversight and making sure that the program is functioning. And in order to do that, they have to be high level, they have to have the authority and resources in order to execute that plan. Also in your program, you're going to have to outline how you plan to screen your employees. There's a variety of ways to do that. OIG and CMS provide screening capabilities on their website, but you want to identify individuals that have been involved in criminal, civil, or administrative violations under the SSA, and you need to figure out, how often you want to do that. Some places do it on hire, or just prior to hire, and other places do it annually, or they space it out, throughout the year on anniversary dates or something of that nature. But you need to decide for your group what's the best way to screen your employees. You have to be able to communicate your policies and procedures through everyone in the organization. Usually this is done through some sort of a training program, and entities of a certain size, it's required as an annual training program. We'll see that in just a moment. But other folks could provide pamphlets or something of that nature. But you have to have a training program that everybody in the organization has access to understanding what the ethics and compliance plan is. You have to have an auditing and monitoring system that will detect and catch these violations. So you have to have a robust plan. So first of all, you have to identify where your areas of risk are, and then secondly, you have to make sure that you're monitoring those. You have to make sure that there's a reaction to your findings, right? That there's an appropriate disciplinary action when needed, and that means not only if you find out that somebody was doing something wrong, but also if you find out that somebody knew about it and didn't report it. That's equally egregious in the eyes of CMS. To know about something and not report it is just as bad as doing it yourself. And then the other piece of it is, again, this concept of excuse me, closing the loop, right? Someone makes an allegation or brings forth a concern, you do your investigation, you have to respond appropriately to every violation that comes in through your feedback, compliance, and ethics methodology, whatever that is. And then if you determine that there is a violation, you have to take steps in order to make sure that that doesn't happen again. Next slide, Jen. So here's where I started when I was mentioning if your organization is 5 or more centers, your training is mandatory on an annual basis. So everybody in your center has to go through this training. You must have a compliance officer, and their primary responsibility is the compliance and ethics program. Smaller organizations, you can wear additional hats, but once you hit that 5 centers, you have to have somebody that is solely responsible for compliance and ethics, so that's their primary responsibility. They have to report to the organization's governing body and have the same standing as the C-suite, the leaders. So the CFO, the COO, the general counsel, they have the same level of authority and access to resources as the other board members, and also, or the other governing body, and also there needs to be a compliant liaison in each of the centers. So you have the compliance officer, and then there's somebody acting as a liaison in each of those centers if you have 5 or more buildings. Next slide. So turning to QAPI, similar to the compliance and ethics program, you have to have policies and procedures. Again, you're building on information that you've already worked through in phase 1 and phase 2. At this point, you're going to revise your policies and procedures to talk about how you're going to get your feedback, how you're going to collect your data and information from those data collection systems and monitoring that. And they mention specifically adverse event monitoring. So that needs to be on your agenda for your QAPI meeting. You need to be monitoring for adverse events. And the policies and procedures, when you're putting them together, minimally have to talk about how you're going to maintain your systems. Once you determine, that you're going to get feedback, how are you going to maintain and use that feedback? And you need to get it from, as I mentioned, a variety of sources. And here's where I started talking about, you really want to start to detect or figure out when you're planning your QAPI agenda, is look at things that are really high risk, that happen once, and happening once, like an elopement, really has a lot of risk for the resident and for the staff. In something that happens in high volume, so maybe meal trays going up, things that are problem prone. So maybe it's has to do with activities or something of that nature, but you want to look for things that fall into those buckets, and then where your opportunities are improvement in those areas. You also have to maintain ways that you can identify, collect, and use data from all departments. So from direct care staff, other staff, but really all departments, and not just stop at that facility assessment that you did back in the earlier phases. So you want to really sort of flesh out what you're going to do with what data you're going to collect, how you're going to collect it, how you're going to monitor it, and that it covers a broad spectrum of locations. Next slide. When you're working on that QAPI plan, you want to make sure that in your policies and procedures, you've got the development and monitoring of the KPIs that I mentioned earlier, and also that you want to look at the frequency for how you're going to develop them, monitor them, and evaluate them. So it doesn't mean you have to do everything every quarter or every month, right? It just means that you need to attend to them and you decide what the cadence is for that review and when you need to make changes. The adverse event monitoring called out specifically, and how you're going to identify, report, track. I mean, use the whole QAPI program around adverse event monitoring. And they also mentioned that resident rights violation is something that must be tracked during QAPI. So we've talked about the rules or requirements for participation in phase 3, and I really want you to keep in mind some of those concepts that I brought up with regard to compliance and ethics and the QAPI program, and start to listen to what Jen's going to share with you about PDPM and see how that ties in together.
Okay, thanks, Pam, and that means I'm back up. So, you know, the things that jumped out to me when Pam was talking about compliance programs and focusing your QAPI priorities are the same old language that we're used to hearing: high risk, high volume, problem prone. Well, think about Medicare and how you're establishing your Medicare reimbursement. This also gets into resident rights, of course, because these residents are the beneficiary of the Medicare program. So it's incumbent on the team at the SNF to make sure that the resident is getting the full benefit of their Medicare entitlement. So think about, as I said, high risk, high volume, problem prone. Well, high risk, Medicare is quite high, become very high stakes recently, and that leads into the reason for PDPM in the first place. CMS had been saying for years, as well as the OIG and MedPAC, about how SNFs are gaming the system. They are pushing volume rather than the quality of care, regardless of resident need. Everybody's getting exactly 720 therapy minutes, and it's not based on actual clinical patient characteristics at the individualized level. Well, that's pretty high risk. That's that's actionable under the False Claims Act if the OIG identifies true, to use the F word, fraudulent behavior at the SNF. Now, of course, that involves a lot more than just providing 720 therapy minutes. There needs to be the intent and the willful fraud involved in that. But still, it is very high risk area, and we also know it's very high risk because CMS is going to be watching. They have been watching, and they're going to watch the transition to PDPM. So it really would behoove you to identify specific areas in your facility that you know are going to show up very starkly between September 30th and October 1st when the switch flips to PDPM. Now, even though there are fewer assessments required under PDPM, you've got the 5-day, and that's it, unless there's an interim payment assessment until the day of discharge for a resident. But that just means that there's so much more riding on that 5-day that you want to make sure that you're getting it right, because you really just get one shot, and there's no recalibration of reimbursement every 7 days like there is under the RUGs. So think of it in those terms when you consider PDPM and what we've been talking about in all of our previous webinars. All of the pieces of PDPM, the various case mix components that come together to form the resident rate, have different parts to it with input from members of the interdisciplinary team. Again, think of your QAPI team that needs to include representation from all members of your team, from the administrator down to the CNAs and the dietary staff. Everybody should ideally have input into PDPM, and really that interdisciplinary communication when you're building a 5-day assessment for a resident, that type of communication should also be part and parcel of your QAPI program, because everybody has a stake in ensuring the appropriate care for your residents and ensuring compliance for the facility. But there has been some crazy that has been happening over the last year and a half or so, ever since PDPM first appeared on the horizon. You're not hearing this quite as much, but the initial reaction of some providers and some thought leaders in the SNF space and post-acute space talked about cutting MDS staff because there's only one required MDS, and we don't need all these people doing assessments, or well, therapy doesn't count anymore, so I guess we're not going to give therapy anymore. Like, that's not a compliance and ethics issue in and of itself. I'm not sure who the new patient coming into the SNF is going to be as of October 1st, but I'm sure they're going to look exactly like your patients who were coming into the SNF on September the 30th. So I don't think that's the case. Maybe some providers will be exiting the space, but chances are just about every SNF provider in this country is used to adapting to changes in the regs and changes that CMS rolls out, and they'll adapt to PDPM as well. Now, need to hire an ICD-10 coder with certifications and specialized and all kinds of special credentialing. That would be nice, but very few SNF providers have the luxury of devoting an FTE with specialized training to that specialty. But knowledge in ICD-10 coding and a firm basis in doing those codings, that ICD-10 coding appropriately, is very, very important to PDPM. So how do you succeed under PDPM? Think of this through the ROP lens, okay? PDPM, I'm not sure who came up with this acronym, but it is a patients-driven payment model, and I think that's really the key. Slow down for a minute, look at your facility, look at your residents, take the time to actually assess them. You're not looking at capturing the most therapy minutes, you're looking at capturing the fullest picture of the resident's acuity during the first week of their stay in the SNF. So being patient will lead to a more full, accurate assessment of the resident and better care, as well as appropriate reimbursement. Of course, you're still going to give therapy. Your therapy teams are not out on the streets looking for new jobs elsewhere, I assume. But how you apply that therapy in the new PDPM paradigm is going to really determine your success as an interdisciplinary team. Of course, your MDS coordinators are very, very important, and continue to love them and cherish them because they are going to be even more important after PDPM comes around. And they should also be leveraged with they already got quite a bit of knowledge and expertise in ICD-10 coding, and they're learning more and more as time goes on. So they and other specialists in your facility really need to champion ICD-10 throughout the organization, and not just picking the right code. It's not just picking the right code, it's making sure that the interdisciplinary communication, particularly communication with the physicians and nurse practitioners, and getting the documentation in place in a timely manner ensures the best assessment of the resident, first of all, and also importantly in the context of this webinar, compliance. Now, I want to point out a few bullet points on this screen that kind of overlap with what Pam has described as far as the phase 3 requirements are concerned. So education of your staff is extremely important, not just for anything you've identified in your facility assessment that requires specialized a specialized approach from your staff, but PDPM is extremely important in this way because that involves the entire facility. It's not just a segment of your, well, it is all your Medicare population, but it will involve the entire facility. So good education frequently is very important here. The key financial drivers, evaluate them periodically and benchmark them, that's QAPI. And making sure that your required compliance plan in the last bullet there covers your new realm of PDPM, because it does put compliance under a slightly different lens than it has been currently, and some might argue just aligning it to where it should be anyhow. So think about a few things that probably leap to your mind when you think, okay, well, here are compliance concerns. So think about September 30th and think about October 1st. They're right next to each other, but it's going to be a completely different world come 12 o'clock a.m. on October 1st. If your MDS coding practices change abruptly, even for the same residents who were in the facility, and then you do that first IPA to convert them to a PDPM, if that person changes from one day to the next, that's a problem. If you have an outlier of key payment drivers, so your rates of, let's say swallowing disorders or mechanically altered diets or things like that are way above whatever national benchmark is established after a few months of PDPM, you probably have a red flag. Now, big changes in therapy. We know CMS is going to be tracking therapy delivery. They're going to be capturing therapy delivery for the entire Medicare stay on that discharge MDS. So, changing the therapy delivery that you have been giving all along, even though it's really measured in snapshots right now in the RUG world from MDS to MDS, CMS is still tracking this, and if they see a real change or significant cut in therapy delivery, there's going to be another red flag. And overuse of IPA. Now, overuse is subject to interpretation right now, because the requirements and the guidelines are just that. They're basically pretty sketchy, and the IPA is not mandatory. So it's up to the facility whether they're going to do an IPA or not. But, at some point, I have to say in my gut that CMS is going to start putting guardrails around that process. So you do want to make sure that when you're doing an IPA that you have really, really good documentation to cover it. Not to be alarmist. So think about fulfilling two needs with one deed. You do need to be ready for both of these things, but making sure that you cover the bases with your interdisciplinary processes, good documentation, thorough assessment of the resident, good communication between the disciplines, both within your facility and with your medical staff, your physicians, and any consultants will provide the best care for the resident and accurate reimbursement, which is what CMS is idealistically driving towards with PDPM. But you won't get that great new appropriate reimbursement without an accurate coding of the MDS itself. So we bring out this slide occasionally. Of course, we redo the analysis periodically, but the last time we ran this analysis was in 2018. And basically, for those of you who are not PointRight clients, we do analyze MDSs for what we call data integrity issues. And these are, disconnects in the MDS that may lead to a false positive or false negative, whether it's a QM trigger or some other condition on the MDS. Obviously, inaccurate reimbursement and case mix adjustment, and in many cases, inaccurate care plans, and could lead to adverse consequences in the surveys. If now that surveyors are really paying more attention to the MDS with their new survey process, or at least the data driven by the MDS. So we looked at just under 24,000 MDS assessments during that time period and found that 79% of those assessments had at least one data integrity issue. And we do this analysis, as I said, just about every year or so, and that number has always stuck around between 75 and 79 for as long as I've been working at PointRight. So if you think about QAPI, we've got the 5 components, we've got the 12 steps, but the process really starts from the bottom, but from the top, because the leadership really needs to be on board with this program to drive the interdisciplinary team to ensure that that QAPI program is getting off on the right foot. Now, everybody has begun the basics of QAPI over the last couple of years, and I'm confident that all of your QAPI programs are up and running and doing what they're supposed to be doing. But particularly when we talk about PDPM and MDS accuracy and documentation accuracy, this piece around here, the feedback data systems and monitoring, the systematic assessment, the systemic approaches are really, really important to make sure that you get systems in place to capture the appropriate data to drive your PDPM reimbursement. So use your data, whether you're using PointRight to identify data quality issues, or your EHR, or another analytics platform, or doing it, with manual audits, God help you. Whatever you're doing, use that data to show you where your opportunities for improvement are, or your gaps. And that's where you can prioritize your performance improvement plans and get down to the root cause, whether it's a piece of documentation that just kind of fell by the wayside, or some staff turnover that needs more education. And that enables you to roll out your improvement system-wide. So MDS accuracy is kind of tailor-made for this, because there are so many moving parts. There's so much interdisciplinary communication involved in the MDS, and so many pieces of the MDS that have been there since 2010, frankly, that are getting a fresh look because they're driving PDPM reimbursement now. So this is a great compliance program for you. So I put together this slide when I was doing an on-site training with a client a few weeks back, and we've been using this slide in all of our webinars as well, but I wanted to call out specifically what's new in the MDS that are driving a lot of your PDPM reimbursement. So if you think about this primary SNF diagnosis, of course, why is this person in the SNF? Why were they discharged here from the hospital instead of going home? That may not necessarily be the hospital diagnosis, but that's going to take a lot of practice and communication between the interdisciplinary team and the physician and the therapy department and the nursing department to come to the appropriate primary diagnosis. Now, this is going to be brand new as of October 1st, the surgical procedures. A whole new chunk of Section J is being added to the MDS. So that's something you will need to keep an eye on as you get used to it. Section GG, as I mentioned earlier, we're not used to it actually affecting reimbursement in any way. So taking a fresh look at Section GG coding is going to be really important. Other things such as the comorbidities and diagnoses, these are pieces that, the process for coding those items have not changed. The manual is exactly the same, but it would behoove you to pay more attention to them if you find gaps in that documentation. So I came up with a few examples of potential MDS coding issues that you will want to look out for. First of all, the primary SNF diagnosis, because everything rides on the back of that primary diagnosis for PTOT and speech. So if you think about a major surgery clinical category, but no surgical wound, follow up on that. Consider following up on that. Or a CVA, the MDS says that the resident has their primary clinical category is acute neuro because of a CVA, but there's no sequela from that CVA, no hemi, no speech disorder, no swallowing disorder, no cognitive problems. Revisit that and just make sure that you're capturing all of those comorbidities that go along with that stroke. Comorbidities without a diagnosis. So coding that diabetic foot ulcer, you would expect to also code diabetes. You don't just code one, you have to code both. Or that hemi without a CVA. Okay, let's look at the documentation and see if that CVA is still an active diagnosis, or if it perhaps was a CVA from 5 years ago and the resident has the flaccid hemi from that, but it was the acute phase is long gone. Same goes with treatments. Now, this is something that, of course, has been under the microscope for a long time. Treatments or therapies without a supporting diagnosis. So if you're coding suctioning on the MDS, but there's nothing to suction, nothing there, you certainly will want to make sure that the reason for that suctioning is covered. Insulin injections without a diagnosis. These are things that you would really consider to be no-brainers, but sometimes under rugs, it's very easy to just let those fall through the cracks because they're not directly impacting reimbursement. And Section GG inconsistencies. So Section GG is very different from Section G. I'm not trying to equate the two one-to-one, but there's a lot of overlap. The time periods overlap, and there are some things that just simply could not happen. For example, total independence in one place and extensive assistance in another during the same time period. It just doesn't happen. It's not possible. Or an activity that did not happen at all, but was coded somewhere else in the other section. So that comes down to interdisciplinary communication, and of course making sure that that physical function assessment is not siloed to therapy or to the CNAs. It should be interdisciplinary. I need to speed up a little bit here. We have been looking for the last several months at current coding behavior on the MDS. Of course, right now we have the 5-day and the 14-day MDS. Well, the 14-day is going to go away, but we did notice some interesting patterns in MDS data from folks who send us assessments of what's not captured on the 5-day, but ends up being captured on the 14-day. And usually those ARD time periods overlap with each other significantly. Sometimes they're only 3 days apart. So if we just bring up our slippery slopes facility, our example facility that we've been using a few times, if we look at the facility rates of depression at 6%, swallowing disorder at 9.1%, mechanically altered diet at 17.4%, and cognitive impairment at 4%, and we put that up against the national average that we've calculated from the data set, we see that this facility is a significant outlier, particularly if we look at swallowing disorders, a good 6% above the national average, where the mechanically altered diet utilization is quite a bit lower than the national average, and the cognitive impairment is way below that average. So either you've got a significantly different resident population, or there is an assessment issue. Now, if we look at the 14-day and we see that the rate of depression has jumped up by 4%, swallowing disorders has decreased, but mechanically altered diets have increased, now that could very well be the reason for the decrease in the swallowing problems. And cognitive impairment has kind of surpassed the national average. What we're looking at from the outside is telling us that there are financial drivers that are just simply not being caught until they're too far downstream to affect the 5-day. So the idea is to move that whole process a little bit further upstream to be successful in PDPM. So think about it as a game. If you're familiar with the Donabedian model of process improvement, structure, process, and outcome. So structure is the rules of the game. We've got lots of rules that we're playing by, or requirements, depending on who you ask. The process is how that game is played within the rules, and the outcome, who's winning. Well, hopefully both you and your patients will win. So if you think about the structure, process, and outcome in your own facility currently, having the appropriate policies and procedures and your regular meeting cadence and your staff education and making sure that you're meeting all those mandatory compliance pieces is extremely important, because without it, the process doesn't have a place to function. So within that structure, you can then have your interdisciplinary communication, your documentation to capture accurate assessment of the resident, and that leads not only to successful PDPM outcomes, but accurate QMs and accurate 5-star ratings. So really important for winning the game. So Pam, I'm going to pass it back over to you for the next few slides.
Great, thanks, Jen, and thanks for that overview of PDPM. And I'm sure that I can almost smell the smoke of what people are thinking about and identifying risk and how they can move that into a compliance plan or a QAPI plan. So hopefully the rest of you are feeling that as well. Next slide. One of the things that we did want to talk about when we start to think about PDPM and compliance is that really what constitutes skilled care, what constitutes accessing your Medicare benefit hasn't changed. And so we wanted to make sure that folks have an awareness of that. Really we want to make sure that you don't lose sight of that, the basics with all these changes that are going on. You still have to, as a provider, evaluate whether or not that Medicare beneficiary is at a level of care and it's medically necessary. So it has to be skilled level of care. From the requirements, it's in the RAI manual, it's in the Medicare manual, and also that it's medically necessary or reasonable and necessary when you're delivering it. So again, it's incumbent on the provider to make sure that it's a skilled level of care and that they're delivering services as they should in the amount that it benefits the resident to treat or diagnose a condition that they have had. Next slide. When we talk about skilled level of care, the basic elements of that are that you do have to have a physician's order, admit for skilled care 2, and then, whatever else you want to add after that. Skilled level of care is considered skilled nursing or rehab services that are provided by or under the direction of properly licensed personnel, that they're delivered in the cadence listed here, 7 days a week for nursing, 5 days a week for therapy. And the thing to remember when we're talking about skilled services is that they have to be provided for a condition that was linked to the resident's inpatient hospital stay, or a condition that arose during the stay, or in the SNF when they were getting care for that hospitalization, the inpatient condition. So those have to be in place as well. And the other piece of it is that as a practical matter, the service can only be delivered in a SNF. So skilled level of care has all of these requirements. Next slide. We did, not that long ago, there was a training that went on for the quality reporting program, and also they slid in some PDPM in that 2-day training. And we did get a heads up from CMS that they are, they're going to be watching. They, just like any new program, that when there's a transition to a new payment methodology, they are watching to be sure that when they are doing a review, they're going to look to see, is a documentation in place to support the diagnosis coding and the assessment, probably more so than they necessarily might have done before, because remember, in the current system, we're really driven by and large by the amount of therapy that we deliver. So again, when they're looking at testing the integrity of a program, they're determined that, they're going to be able to see very clearly how the facility is doing when they're looking at the documentation. Next slide. Also, some of the elements that they said they would be looking at, and they're ones that we alluded to earlier, and when you start to think about PDPM and where compliance crosses, it makes perfect sense, right? Jen talked about how important that diagnosis was when determining what the group is that they'll fall into under PDPM, where their components have them land. This diagnosis is really important. So making sure that there's documentation to support that that ICD-10 primary diagnosis, right? It has to be there. If you're delivering therapy in a different way as compared to how you would deliver it under RUGS 4 by intensity, duration, or mode of delivery, they're going to be watching that as well. There was a lot of conversation when we made changes under the PPS system, and CMS saw all the therapy we were delivering and that it was individual therapy, and we made a case as to why it had to be individual therapy. With every adjustment under PPS, they've seen behavior changes, and they're going to be watching for that behavior change now. Again, as Jen mentioned, mechanically altered diet is a driver under the speech language pathologies component of PDPM. They're going to be watching for that. You can believe they have a long history of that data. We've been coding that for a long time, and so they're going to be watching. And then any anomalies in the comorbidity coding, right? They have a huge data set of MDSs. They know what are the frequency of seeing a lot of these different comorbidities were based on that information. And so looking for any big changes are going to give them, perk their ears up, or as Jen says, raise a red flag. Next slide. Again, as we mentioned, this primary diagnosis is really critical. And then also when you're looking at a surgical procedure, again, that has an element that adds into your PDPM rate. And so knowing that whether or not there was a surgery in the prior proximal or the immediately prior hospital stay is going to be important. So making sure that you have the primary reason documented, that understanding that it might not be the same one that they that they had in the hospital. It may be a secondary one that arose while they're in the SNF, but that should be in the medical record and easily found. And Jen talked about the interdisciplinary team getting together and really saying, why is this resident coming to the SNF? They're coming to us for a specific reason. Otherwise, they'd be going home, right? So knowing what that is, having consensus around the primary reason, reviewing that with the doctor, or making sure that you have that in the hospital record and you bring that forward into your decision-making process, that information will be critical. And as I mentioned, making sure you have the surgical procedure documentation captured. Next slide. Again, the interim payment assessment, as Jen alluded to, is voluntary. There are no real guardrails or guide rails around that now from CMS, but they expect that centers and organizations will create their own, that they will have a process, a mechanism to identify changes. They should have it in place now, and it should be used for everybody. And they also want to know that there are ways that you have a process, right, in your center to identify when someone should have an IPA, when that's necessary to do. So making sure that that's scripted out, that it's crafted is going to be critical, because again, if they start to see an uptick in IPAs or an overuse, they're going to start looking at whether you're an outlier or not. And so reading between the lines, I mean, we've sort of talked about this a little bit, we want to make sure that you're looking at your IPA criteria, that it's always based on your center, your residents, that it's specific for you, that you have a way to check and make sure that you're watching for changes. You should have something like that now, but again, having it as a systematic and routine is going to be important, and that you're consistent with how you apply the criteria. So basically, when you look at this, it just screams QAPI. So look at the overlaps, and I'll pass it on to Jen to bring us home.
Bring it home. So hopefully you see where we're getting at here, because QAPI and PDPM really do go hand in hand, particularly with the compliance. I was going to say minefield, but that's a little bit extreme of a metaphor, but it's going to be some rough waters, at least for the first quarter in PDPM, as facilities truly meet the reality. So leverage your structure, process, and outcome that you already have in place. You already have interdisciplinary team meetings. You already have a core group of clinicians and staff who are attending these meetings. So take a look at your current SPO, structure, process, and outcome, and make sure it's still working for you, because there's no need to reinvent the wheel. Medicare meetings are still going to happen, but see what other requirements you can cover with the same meeting. So I just sketched out some ideas for your brand new admissions, for example. You have to determine that primary SNF diagnosis and identify any surgical procedures. Oh, by the way, there's the medication drug regimen review that's required at the beginning of the stay as well. So that communication with the physician that you have to do, cover both of those bases with one or two conversations with the physician. Efficiency is really helpful here. So within the first 3 days, of course, you need to make sure that section GG assessment is being done by the interdisciplinary team, overall shifts to determine usual performance, not just one therapist filling out section GG and that's it. You have 8 days. You have days 1 through 8 to set that ARD. Use that time. Don't jump to automatically setting the ARD on day 5 or whatever practice you used to have, because you do need to be able to be sure that you have the appropriate documentation to capture resident comorbidities. And then ongoing basis, monitor your Medicare residents. You're not going to spend every day saying how many therapy minutes and what were the ADLs anymore, but that is important to know how they're doing, if there have been any changes to the interdisciplinary assessment in any area that might trigger a potential IPA. And of course, for the entire Medicare stay, you do need to make sure that you're still meeting the criteria for a daily skilled level of care. So really, really important to leverage your current Medicare meetings, but take a slightly different spin on them. MDS coding, I know we're up at the end of our time here, but we don't need to emphasize this we can't emphasize this too much. Whatever auditing method you use to identify issues with the consistency of your MDS coding, use that information to identify any recurrent issues or any patterns or issues with the documentation so that you can focus on them. This is a perfect QAPI program to dig into an area that may be missing. Maybe it's getting those physician's diagnoses documented in the record in a timely fashion, or issues with educational needs resulting from staff turnover or time management that are causing the CNAs to not get all their documentation in by the end of their shift, for example. And just simple data entry errors. They happen, typos happen. Spell check has saved my life many times, but just make sure that you are appropriately auditing those MDSs before they get sent off, because it all rides on the 5-day, barring the existence of an IPA. So pick a couple of sections of the MDS that you might need to work on that drive PDPM, set up a PIP for that area if you haven't already, and go to town, see where it takes you, because what we would like to see is that you're ready well before October 1st hits to capture that full picture of the resident's condition and get the right reimbursement and reduce your compliance risk. So we did talk about a lot of regulatory language from CMS. So I have 2 pages of references here for you today. The ROP website, you can download the full requirements of participation. CMS's PDPM website, they continue to update their FAQ document. I do recommend you download the current version. It's become very comprehensive. And the Medicare Claims Processing Manual, that has not changed, and it's not going to change anytime soon, but Chapter 6 is where the action is for SNFs. And we alluded to the SNF QRP provider training that happened back in May. May 8th was the day 2, where John Kane got up and talked about PDPM unexpectedly, but you can download that information and the handouts from that presentation where we got those quotes from. If you go to this page, this is the zip file you want to download from day 2. So thank you so much for your time. Unfortunately, we don't have time for questions because we used up our whole hour, but just know that our next session will be sometime in September. We'll talk about the home stretch because there's only so much time left to do more PDPM webinars. So we hope you'll join us for that. Thank you very much. I'm going to move on to the CEU slide so you can see the URL for that. So as usual, once we finish with this webinar and get our attendance list, we will send out an email with a link to our SurveyMonkey. Everybody who attends this webinar live should fill out the SurveyMonkey separately, so forward it to your colleagues who are attending in the same room with you. Please complete the survey and enter your own information by Friday the 28th so that we can compile the attendance report and report who logged in. For nurses, your certificate of completion for 1 contact hour will be available for download after you complete the survey. Nursing home administrators, please provide us with either your NAB ID number or your state administrator license number so that we can report to the NAB CEU registry, and NAB will handle all of the documentation requirements for that. Okay, well, thank you all so much for your time. We did run over just a little bit. Sorry about that, but I hope this has been useful to you, or at least giving you some food for thought for today. And Pam, it's been a pleasure.
Thanks, Jen.
Take care, everybody. Bye.